Stages of labor. Now, in the first stage of labor, there are 3 phases. And phase 1 is latent or early labor. Phase 2 is active labor. And phase 3 is transition. In latent or early labor, contractions are irregular, anywhere from 5 to 20 minutes apart, lasting 30 to 60 seconds. Cervix begins to efface and dilate up to 3 centimeters. Bloody show may be present. Spontaneous rupture of membranes may occur. It may come as a gush of fluid or just a constant trickle. And this is the longest phase of labor, so it could be days. So the time is really unknown. Phase 2 is active labor, so may last 6 or more hours. Contractions are stronger, they last from 40 to 60 seconds or longer, and usually about 2 to 5 minutes apart. It needs to be consistent, 2 to 5 minutes, lasting about that minute in duration, to really change the cervix, to push that fetal head down and change the cervix. There's a distinct peak in the contractions. Dilation is from 3 centimeters to 7 centimeters in this stage, and bloody show usually increases. And there's also an increased pressure in the back and in the vagina as the baby starts to descend. You can see on this slide how the cervix is opening. That's probably where your 7 centimeters is. And the baby's head is really starting to descend into the vaginal canal. Phase 3 is transition. So this is the most demanding phase. So this is from dilation of 7 centimeters to 10 centimeters. And this could take just a few minutes, or it could actually take a few hours. Your contractions are very strong, lasting anywhere from a minute to a minute and a half, and they're 2 to 3 minutes apart. And remember, with contractions, this is uncontrollable contractions with the body. Bloody show increases. There's a strong pressure felt in the back, the vagina, and also in the rectum. And that's, like I said, due to the presenting part, the fetal head, coming through the vagina. And there's also that strong urge to push in transition. In the second stage of labor, this is where all your pushing comes in. So this is from 10 centimeters to the actual delivery of the baby. So this can be a few minutes to a couple hours. Now, what you'll really hear some of your nurses saying about laboring down, they're saying that because even because you're 10 centimeters, it doesn't mean the baby's going to fall out. So depending on what station that the baby is in, the doctor might recommend for you to labor down, which means turning you from side to side, putting you into different positions, using the peanut ball, anything to kind of help open the pelvis and get the baby's presenting part to move further down into the birth canal. So, like I said, just because you're 10 centimeters doesn't mean it's time to push, because we really don't want you to have to push for 2 hours if that's the case. Contractions might be slightly less painful, lasting 45 to 90 seconds, which is a minute and a half, and every 3 to 5 minutes apart. You may feel some burning or some pain in the vaginal area, and that's due to stretching. And as the baby's head crowns, it'll start to appear at the vaginal opening. Then the doctor will deliver the head, the shoulders, and then the rest of the body. And you can see in this picture where the baby's head is actually starting to crown. The third stage of labor is the delivery of the placenta. Contractions are mild as the placenta separates from the uterine wall. It usually takes anywhere from 5 to 10 minutes after delivery of the baby. Comfort measures during labor. Now, there's different types of natural childbirth techniques that I have listed here, and you could write these down and look these up on your computer to really give you an idea of the different types of natural childbirth is out there. So basically, it's whatever you decide would work best for you. Some people choose Bradley method, some people choose Lamaze, some people take different parts and pieces of other different things. It's just really whatever is useful for you to help you concentrate and for you to have the best experience possible. Now, I have listed on here water delivery. Now, there is such thing as water delivery, and I'm sure y'all have all seen videos. However, here at St. Tammany, we do not do water deliveries. So if that is something that interests you, I'm sure somewhere in the area that there could be some type of childbirth clinic that might perform water deliveries. But like I said, here at St. Tammany, we're not, capable of doing water deliveries. During natural childbirth, you can use the birthing balls. You can either bring one that you have, or we have some here. It helps with opening the pelvis and the bouncing and kind of rolling around on the ball and rotating actually helps with pain and back pain and for comfort measures. Also, position changes helps. There's what's called a squatting bar. And if you look down at the bottom of the picture to the right, that is a picture of a bar, the squatting bar. The bar is detached from the beds when y'all are admitted, but if you want to use a squatting bar, let your nurse know, and they can attach it to the bed for you to use. Massage is also helpful. Usually that's something that the significant other can help with. Anything to help with distraction, massaging the lower back, massaging feet, anything to help you be more comfortable. Now, there will be times where, and this is for the significant other, where the mother might tell you, don't touch me. And that's perfectly normal. So don't take anything personally. It's just at a point during labor where they really need to concentrate, and it might be a little more of a distraction than what they need. Hot and cold compresses also help. We even have some physicians that will have us put warm compresses on the perineum to help during stretching when it comes time. Breathing and relaxation techniques, and that's some of the things you can really learn by watching those other videos about Lamaze and about Bradley. Ambulation. If you're not too far dilated and you're able to ambulate, and your doctor says it's okay, excuse me, or also if if your water's not broken, we'll allow you to ambulate. And then also having a doula or a coach. Sometimes your significant other is also your coach, so that's wonderful. However, like I said, due to COVID, we're only allowing one visitor, so if you decided you did want a doula, we wouldn't be able to allow a doula and your significant other, so that might be something you'd want to think about. Medications. IV narcotics can be used. It's not something that we use routinely. That was something we used to do, 20 years ago or so, more than what we do now. We definitely cannot give any type of narcotics to close to the delivery of the baby, because of course it goes to baby as well, and it does take some time to metabolize and get out of the system. But we can give medication that, IV narcotic that does help, with resting in between contractions. It's not something that completely takes away the pain. It just kind of helps to lessen it, so you're able to get a little rest in between. Usually the medication we use is Stadol or morphine. It does cause drowsiness. There are some people who say that they don't like it because it does kind of give you that loopy feeling. So where you're still kind of loopy and still having pain and discomfort. But then other people say it just took the edge off, so they were able to, sustain. An epidural numbs from below the breast down to your toes. You're still able to move your legs, so that's normal. You'll still be able to feel pressure and touch. However, you shouldn't feel the discomfort of pain. Now, I will have to tell you that if you kind of think about pressure compared to pain, like let's think about like diarrhea cramps for a minute. I know we don't want to talk about diarrhea, but let's talk about diarrhea. Diarrhea cramps, when you're feeling those abdominal cramps, that's really pressure. It's not really pain, because there's no like pain, neurons like in your gut, but there's pressure that you feel. So you might feel like cramping as far as some pressure, kind of feels like pain, but it's not the sharp kind of pain. And if that doesn't make sense, let me know, and I can, try to help describe that a different way. But just to let you know, like, an epidural it takes away the pain, but as far as the pressure, that pressure sensation would still be there, okay? Now, if you plan on having an epidural, we have to have an order from your doctor. You must have IV fluids given prior to, during, and after the epidural, because the epidural does relax your vasculature. So we have to make sure that we keep your blood pressure up with the IV fluids, to maintain your good blood pressure for you and for baby. The medication does not run out. You'll hear people say, oh, I got an epidural, but it ran out. It doesn't really run out because we have it on an IV pump and it runs continuously. And then you also have a button where you can actually give yourself a little bit more medication. Now, if it gets to where it doesn't feel like it's enough, all we have to do is call the anesthesiologist or a nurse anesthetist, and they can come and give you a little more medication. Okay? So you just have to keep your nurse informed of how you're feeling. Let's see. Able to move your legs, and we did talk about that. So you'll be able to move your legs, but they're just going to feel really heavy. So they're going to feel different to you, heavy. You might have a little more heaviness to one side than the other, and that's perfectly normal too, okay? Now, the epidural procedure itself, we have to give you a full bag of IV fluids before the epidural, and like I said, that's due to the decrease in blood pressure with the medication. We'll have you sit on the side of the bed with your feet dangling, and you can see in the picture that's how she's seated. In the picture, we have a support person, her husband or her significant other that's holding her in position. Now, here at the hospital, we don't allow that. We actually have the significant other sit in a chair at the bedside. So the nurse would be holding you into position. The anesthesiologist will talk you through the entire procedure, tell you exactly what to expect and what's going on. At first, he'll clean your back, with betadine, and if you have an allergy to betadine, they can use, chlorhexidine. So they'll tell you that's going to be cold, you'll feel cold, and then they'll use the numbing medicine, which is the lidocaine, and they'll tell you, okay, you're going to feel me touch you, the pressure, you might feel a little sting from the lidocaine, and then from then on out, it's just a matter of pressure, okay? Once the doctor has everything in the epidural space, he'll put the medication in, and it takes about 20 minutes to get full effect. So we'll warn you of that as well. It takes about 20 minutes before you really start to notice any change in your contractions. But one by one, they'll get less and less until you can't feel that discomfort anymore. So after he gets all that ends in place, they'll tape it up your back, and then we can get you back positioned in the bed. Now, since you'll have an epidural, we have to put in a Foley catheter into your bladder because you won't be able to feel that sensation of needing to urinate. And we also need to measure what your fluid output is, since we're putting fluid in your body. Okay? But we wait until you're completely numb before we do that to you. Now, here's a video of an epidural, which I thought was really good, which is why I put it in here. if you can write down that address for YouTube and watch that video, it's really informative. Now, epidural myths. One myth is epidurals slow down labor. Nope, they really don't slow down labor, because if you're in active labor, there's really not much we could do that's going to slow down or stop your labor. It's difficult to push if you have an epidural. Well, that's pretty much a myth too, because there are ways that we can help you push, and not to mention your body is doing most of the pushing itself with the contractions. We are helping along when you are helping push with your contractions. So we can help you with that if you are having some difficulty because of, increased numbness. Epidurals always work. Unfortunately, there are occasions where epidurals do fail to work, or they might have what's called, they'll create what's called a hot spot, where the epidural medication can't get to one particular area, so then you'll feel pain in that one particular area. So let's just hope that that doesn't happen. There's not much we could do about that. Or if you have disorders of the spine, such as scoliosis, sometimes might work on one side and not so much on the other, but we'll do the best that we can to get your pain under control. The myth, epidurals lead to C-section. Well, that is what it is. It's a complete myth. So no, there is no research or any evidence that a patient receiving an epidural has a likelier chance of having a C-section. There's a window of time to get an epidural. Well, that's sort of true. The only time that you really can't get an epidural is when the baby's coming out. And at that point, it really doesn't matter much. You've already been through the hardest part of labor, and the only reason we can't get your epidural in at that time is because we can't have you sit in that position, and you also can't stay still. Epidurals are scarier than childbirth itself. No, they're really not. So that is definitely a myth. If you can tolerate having an IV placed in your arm, you can tolerate an epidural, because I am not kidding when I say this. 90% of patients that I have taken care of over the years have said that their IV was worse than their epidural. So if you can stand getting stuck for an IV, you'll do just fine with your epidural. Interventions in labor. Augmentation of labor. Pitocin IV infusion is one of the ways that we augment labor. And what we mean by augmentation is basically helping you along. Okay? So you're already in labor, but we want to help you along a little bit. So let's say your water broke, but you're still in early labor. Well, we don't want you to sit around for too long being in early labor when you're ruptured, because there could be a risk of infection if we let you labor for too long. So the doctor says, let's go ahead and give her some Pitocin and help her along a little bit. So Pitocin IV fluid, IV infusion, and also rupture of membranes. So if you weren't ruptured, but you're in early labor and it's terribly painful, it's distressful for you, the doctor might rupture your membranes in the morning, do a little Pitocin, and get labor started. Other interventions are the fetal scalp electrode. That's the top picture. You can see how it's got like the multicolored cord. It's like green and red. And what that is since it says fetal scalp electrode, it is an electrode, and it has little tiny needle at the end in the shape of like a screw, like a little spiral screw. So what it does is it just goes right into the fetal scalp, just a little bit, and like I said, it's very tiny, attaches to the fetal scalp, and that way we get an accurate fetal heart rate on the baby. Because there are times where we have difficulty monitoring the fetal heart rate. This is where we get it accurately. There's also the internal uterine pressure catheter, which I talked about earlier. That's the one that's on the bottom right. That is the catheter that the physician will put in, and then it will measure the actual pressure of uterine contractions. And then there's oxygen therapy. So we will apply oxygen therapy for, periods where if the baby's heart rate drops a little low, or if mom's blood pressure drops a little low, we'll apply some oxygen for periods of time. And position change. So a lot of times your nurses will come in and change your position. That is the very first thing that we do if we see anything that's going on with the monitor. So the entire time we're watching the monitor, we're looking for baby's heart rate reaction to maternal contractions. So we're looking for like a decrease in heart rate during or after contractions. So like I said, the first thing that your nurse will do is change your position, okay? And then of course, sterile vag exams. So occasionally we'll have patients ask, oh, it's been an hour since you checked me. Well, are you going to check me again? Well, it depends. The more times we go in there, the more likely we can introduce a bacteria and can cause an infection. So we don't want to go to do vaginal exams too often. So we do it as we need to. So if we see something on the monitor that we think, okay, baby might be descending further, or there's some type of change going on, we'll do a vag exam. If you're having increased pain and want your epidural, we'll do a vag exam. After your epidural, we'll do a vag exam. If you're feeling more like rectal pressure, we'll do a vag exam. So it's not going to be on a times table. It's not going to be every hour, every 30 minutes, or whatever like that. It's on an as needed basis.